Meeting is now being recorded.
The INCOSE Healthcare Working Group is one of several industry-focused working groups within INCOSE. Healthcare and biomedical applications are still a non-traditional industry for systems engineering, so the Healthcare Working Group was formed to bring together systems engineering practitioners and systems thinkers in order to share experiences and improve the overall state of systems engineering for healthcare and biomedical applications. We also are very interested in working with systems engineers from outside healthcare so that we can learn about the tools and techniques from the traditional systems engineering fields like defense, aerospace, and automotive, and gain experience in applying knowledge from those fields to the problems in healthcare. The Healthcare Working Group has a number of work streams pursuing various aspects of systems problems in healthcare. We welcome all of you to contact one of the working group POCs in order to obtain more information. And we always welcome new participants in our technical efforts. If you drop me a note at the email address shown, I'd be happy to send you a short overview of our group and our activities. Each month I like to highlight some of the recent and upcoming events for INCOSE and the Healthcare Working Group. The annual INCOSE International Symposium was completed just 2 weeks ago. This year there was a one-day track addressing healthcare topics. As you can see from the list of papers, a very broad range of topics was addressed. The unifying theme for this session was the application of systems approaches to key problems in healthcare. Proceedings from the symposium will soon be available through John Wiley. Access to the proceedings is free to INCOSE members. Non-members can purchase access through John Wiley's online store. The next INCOSE Healthcare Systems Engineering event will occur at the INCOSE Great Lakes Regional Conference to be held in Indianapolis in October. This conference will feature an extended technical track addressing integrative healthcare that will include, among other topics, care delivery, medical devices, informatics, and analytics. Additional information can be obtained by visiting the conference website at www.incose.org/GLRC 2018. I want to make you aware of a few INCOSE policy changes that will affect the Healthcare Working Group's communications processes. INCOSE will soon be conforming to the new personal privacy rules established by the EU. Following these rules is mandatory for communications within INCOSE's European sector, and it is expected that similar rules will soon be established by the countries in other sectors. The key outcomes for the Healthcare Working Group is that we will cease using our Gmail mailing list. This mailing list included both INCOSE members and non-members. INCOSE members can sign up for the INCOSE managed mailing list for the working group by logging into their INCOSE account, visiting their member profile, and making sure that in healthcare is one of the committees they have selected. Non-members can stay apprised of Healthcare Working Group activities by joining our LinkedIn group. Webinars and other healthcare systems engineering activities will continue to be announced via LinkedIn. You can also visit our YouTube channel. We will be transitioning to posting webinars on that site as well. Our next webinar will be in October. Announcements will be made via the above channels about 3 weeks prior to the webinar. I'd like to quickly review our SOP for the webinar. We'll have roughly 45 minutes of presentation followed by Q&A. Your phone lines will be on mute during the presentation, so as questions occur to you, please type them into the chat box in the lower left of the Global Meet screen. At the end of the presentation, we'll address the chat box questions in the order they were entered. Due to issues we've had with background noise and feedback, we will keep everyone on mute and will continue to accept questions through the chat box. So as the Q&A discussion proceeds, please continue to enter your questions into the chat box and we'll get to as many of them as time allows. We will make the presentation available. A PDF copy of the slides will be posted to the Healthcare Working Group's public website. We try to keep presentations from the past few webinars available for download from our public website. You can connect to the Working Group's public website from the INCOSE homepage. The presentation should be posted in a few days, and will remain there for several months. Please note that the webinar is being recorded. Webinar recordings currently are stored in the members-only area of INCOSE Connect. Over the next few months, we will be transitioning to storing the recordings on our YouTube channel. Now I would like to introduce today's speakers, Raj Mukherji and Ken Cureton. Raj and Ken will describe the work they've been doing to employ federated clouds to achieve information interoperability across multiple healthcare information networks. In particular, they will describe for us an overall architecture for achieving healthcare information interoperability. Both Raj and Ken are leaders in the Network-Centric Operations Industry Consortium, an international not-for-profit whose goal is to facilitate the adoption of cross-domain interoperability standards. Raj and Ken have significant roles in NCOIC's Interoperability Verification Program for NATO, and much of this work was performed in that program. Raj is the principal and founder of Mukherji Consulting, LLC, a startup company that does systems architecture and provides thought leadership in systems engineering applications in healthcare information systems. Ken Cureton retired from Boeing, where he was a Boeing designated expert for interoperability. He currently works at the University of Southern California in the Systems Architecting and Engineering program. Raj and Ken, welcome to our webinar, and thank you for being willing to share with us your work and innovative ideas. If you'll give me just a minute to stop sharing my screen, then you can begin sharing yours and present your webinar.
Thank you, Bob, for those kind words of welcome. It's been just great to be with you today, and welcome all those who are logged in internationally and in the U.S. Good morning, good afternoon, good evening to you all. My name is Prithviraj Mukherji, Raj for short, and I am associated with Mukherji Consulting, a small consulting company based in Northern Virginia, USA. My co-author, Kenneth Cureton, and I are both members of the Network-Centric Operations Industry Consortium. And at this point, I'd like Ken to put up the first title slide, if you can, Ken.
One second. Let me go to get the slide deck up. Okay, let me check. You should be able to see it, Bob.
It looks like it's starting up, but I don't see anything yet.
You double check.
This work that I'm about to describe, provided it can be shared.
Now you should see it.
Now it's up there, and if you put your presentation into full screen mode, should be, yep, there we go. Perfect.
Thank you.
Raj, you're on screen
Ken.
1.
Thank you. Very good. This work was done over the past 3 years in connection with a number of initiatives. One was the NATO initiative that Bob mentioned. The other one had to do with the NIST, the National Institute for Standards and Technologies, which in collaboration with the Institute for Electrical and Electronics Engineers has a working group of which I'm a member, along with other people from NCOIC, whose charter is to come up with a standard for federating clouds. The NIST already has a standard for cloud technology and how that works. But what was missing was the federation of multiple clouds, 2 or more clouds. And so this working group that I've been a part of is an attempt to come up with a standard. It's emerging, not yet published, to federate multiple clouds. And so those are the 2 basic things that sort of are the context for this. The next slide, please. if you see on the next slide, it gives you a quick survey of where we have been in the last three years. The upper left quadrant is NCOIC, NIST. I've been a professor of systems engineering for Worcester Polytechnic Institute, and I've been working at MITRE in Northern Virginia. MITRE is a federally funded research and development center that assists government agencies with building systems and managing risks. Ken and I are both involved with this interoperability verification program, or initiative, IVI as it's called, and this logo you see there in the left quadrant. IEEE and Worcester Polytechnic Institute are the things that I've mentioned already. The one on the right upper quadrant is the Open Research Cloud Alliance, of which I'm a member and have been actively participating in the discussions on how to federate clouds for researchers, basically, who want to access legacy data in large big data databases. The left bottom quadrant are my experience with the Northern Regional Medical Command, whose logo is the one that you see there that can't be read very well. And I've worked 10 years with Government Accountability Office and their IT division as a senior executive. And then on the right are some of my clients that I've had over the last 10 years. The next slide shows you what Network-Centric Operations Industry Consortium does or is. It's basically a nonprofit group whose vision is to be the thought leader and partner for facilitating network-centric operations and interoperability using as much as possible open source code and standards. So in pursuit of this vision, we held a workshop in 2017. I was the convener of this workshop with NCOIC's help and participation, and it was called Advances in Healthcare Information Technology. This was held about eight months ago, November last year. And periodically, NCOIC has done demos, held workshops, and so on and so forth. This is part of their normal activity. In this workshop, we collected 5 authors who talked about rapid response for disaster recovery scenarios, and the use case that we focused on at this workshop was how does one access healthcare information in a disaster recovery scenario. That was the use case. So it also addressed, besides healthcare information systems, communication systems, because we assume that the existing communication systems in a disaster area would be down. And so how do you set those up rapidly in a matter of hours? And I'm not going to get into that, but suffice it to say that we relied on drones and balloons and so on and so forth to install hubs, communication hubs, and transponders that could be carried in backpacks. So moving on to the next slide. The speakers at this workshop were, as you can see, a wide variety of people drawn from industry. These are people all over the world. We had Dr. Craig Lee from Aerospace Corporation based in Southern California, to the last but one guy here from India, from Bangalore, India. And very interesting discussions at this thing. We had representatives from Europe, Estonia specifically, who attended this conference. And as some of you may be aware, that Estonia has a leadership position in implementing digital platforms and electronic government initiatives in Europe, in the European Union and NATO. The next slide, please. So if you go to the next slide, our approach strategically for improving the delivery of healthcare as well as the operations that involve healthcare information systems that are not associated with direct delivery, such as payment systems, research systems, monitoring, and accessing healthcare information that is not directly related to the delivery and provision of care, has these 5 elements in it. Our approach, the governance model that Mukherji Consulting uses, is 5-fold, with technology being the enabler for monitoring financial customer relationship, satisfaction levels, skill sets, which is learning and growth, and the governance associated with managing projects related to building systems that work. So we've used these 5 things, and we're not just focusing on technology. That's the key thing. And we presented this back in 2016 at the No Magic World Symposium. This is not a new idea. We've been working on this for many years. Next slide, please. So if you go to the next slide, you'll see NCOIC has, over 14 years that they've been around, developed a toolbox, which is shown in the left quadrant here. And there's an NCOIC interoperability framework, a model that allows NCOIC to analyze risks associated with large projects called scope, and then various other tools in their toolbox. We use these when appropriate. In 2013, we had a demo of accessing clouds in a rapid response situation. Basically, a test bed set up to demonstrate rapid response capability. 2012, did an agency study for a particular agency. Labra interoperability demo was in 2010, and of course what's not shown here is the 2017 workshop. So NCOIC has been active in this for 14 years. That's the key thing to remember. It's not something that just started more than a decade and a half now. Next slide, please. So on the next slide, we see that values that NCOIC provides is we have people who are retired 5-star, 4-star general types, cabinet secretary types, political types on our advisory council who can provide guidance to management of our management level folks and the clients that we service. So it's not just the techies that are there in the various groups. We have a very, very senior advisory council, and we do these demo tests. We do execute contracts on a global basis involving European countries, North American countries, Canada, U.S., so on. And the legal environment is, of course, compliant with OMB requirements, Office of Management and Budget requirements in the U.S. In other words, we take great care to make sure that we're vendor agnostic. We don't support any one company over other companies, things like that. The next slide, please. I want to move away from NCOIC into 2 major aspects of technology that are currently in high profile, being talked about, basically. What is not here on the Gartner hype cycle, now this is the hype cycle, okay, so you see blockchain is on the hype cycle over here. It's right here, just to the right of the declining shoulder of the peak. What you don't see here is federated clouds, okay, but we have some of that in this towards the bottom of the peak on the right side where you see enterprise taxonomy and ontology management. That sort of is as close as we get to federating clouds, because without a common ontology, one can't talk from one cloud to another. And that's a requirement, a necessary but not sufficient requirement. So we want to focus on blockchain and federating clouds, which are on the Gartner hype technology, but you see where they are. They're currently, blockchain is very, very much in the hype cycle. This will lead to, this is called the peak of inflated expectations, and that's where we are for blockchain. That sort of transitions, time goes left or right on the x-axis into the disillusionment phase, which is the bottom of the curve here on the right. And then after that, we get what's called enlightenment, realistic expectations, and then we climb along that curve to a plateau where productive systems can be built. So I want to focus on two things, blockchain and federation of clouds. Next slide, please. So on this slide here, you see that the three trends are AI everywhere, machine learning, and very big, but we're not focusing on that in this talk. We don't focus on this immersive experiences, which have to do with things like 4D printing and so on and so forth. We do focus on digital platforms because of blockchain and the Internet of Things platform. So we're in this third area of the trends of that Gartner projected in 2017. On the next slide, I'm going to launch into the three use cases. I have three use cases that I'm talking about. The first use case is global access to healthcare information, provided the people who are involved in this network that's global agree to share their medical information, healthcare information. Right now there are...
Raj, we're on slide 10, correct?
Yes, slide 10, correct. Slide 10 shows a notional connectivity diagram, operational view, a high-level view of electronic health records being shared using blockchains for data provenance. Blockchain basically are these yellow folder-like things that are in between the connection lines, which are internet connections, by the way. The different circles, different color circles, are different healthcare legacy databases. So the ability to create, read, update, and delete the four common database operations, create, read, update, and delete. We want to be able to do that. We can't delete healthcare records, so that would be not a serious thing to do. But the other three, create, read, and update, want to be able to do that on a worldwide basis. Now, this is okay for multinational organizations that have a premise built into them that they will share information, such as NATO, such as the World Health Organization's member nations that participate in, say, monitoring pandemics like Ebola, influenza. There's a need to share information on a worldwide basis so that we're better prepared next time for the next pandemic. In that use case scenario, I have some architecture that I'm about to present. On the next slide, please, Ken, slide 11. So here we have two actors. On the left side is somebody called Bob, anonymous Bob. And on the right side, where you see that cloud, is Alice. And both of these guys have their databases located in some cloud. 5 years ago, I'd say they have databases. But right now, their databases are monitored, are maintained by some cloud services. And they have different clouds, right? So this guy could be in US and Alice could be in Europe. So if those two clouds don't operate or don't interact, then you've got a problem. So we want Bob and Alice to be able to communicate healthcare information and any other information. This is a use case focusing on healthcare. But it could be said of any kind of research data that you maintain on two different legacy systems in two different clouds, such as, part systems for aircraft companies, banking information, you name it, different vertical domains. What we need for this ability to be able to share in the healthcare, we've got these three big red blobs in the center are the ontology. Three areas where you have to have common understanding definitions of terms used to share data. One is clinical area, the other one is the laboratory, radiology, and pharmacy. Radiology is mostly images, laboratory results, how do you transmit those, and pharmacy, details, orders. And then encounter notes are the notes that the doctor or physician or nurse writes when you go to visit them. Enter those notes into some legacy system that they all own. Now, these two systems on both ends, Bob and Alice, don't have to be the same. Bob could be Epic, and Alice could be some other system owned by GE, for example. Casa Permanente, which is not Epic. How do you get them to transmit? Well, they use the internet. That's one. Then they have something called a Federation Manager, a Cloud Federation Manager. And here we use the NIST IEEE emerging standard, this FM thing that you see here on this diagram. Now, FM is over, the Federation Manager software is sitting on top of a security and a blockchain interface software. So there's a stack sort of a concept. So these various levels are providing different services. So beneath the Federation Manager is an identity access manager who manages security. Then you have a blockchain manager. Basically, the blockchain manager takes every transaction that comes along, makes a hash code out of the type of transaction and its contents, hashes it with SHA 256 or 512, takes that hash code and sticks it into each cloud's local database. So if Bob has a local database, if Bob is on a laptop like I am right now, it would go into my laptop's database, that hash code, and a blockchain would be formed in my local. So I have local knowledge about who did what in terms of transactions. That, hey, I sent something to Alice on the 27th of July at such and such a time. I timestamp it, and I have that record. So I have implementation of two ideas here. One is this idea of data provenance. So I can audit trail transactions using a very simplified model of blockchain, not to be confused with Bitcoin. Nothing to do with Bitcoin. This has to do with maintaining a record of who touched the data or who sent a transaction when and what was that transaction about. Now, if I store this in Bob and Alice's, I still don't have consensus. That's just too few people to develop a consensus that transaction was a valid transaction. So what I do is I store it in Bob's, I store it in Alice's local storage, and I also send it to three others on the network who pre-agreed to be on this communication network. They're part of the federation. That way, I've got 5 people now, and if any one of them has a different hash code than the other 4, then we know that particular transaction was tampered with during transition or after storage or whenever. So we have some way, better than no way, of checking on hacking if it occurs on a real-time basis. We can know immediately. The moment we compare those 5 transactions and we compare them right after storage, if one of them is different, we throw that out and say that's not a good transaction, that was hacked. So there's your consensus algorithm that's normal for a blockchain implementation. Moving on to the next slide. The methodology is model-based systems engineering. I'm not going to spend much time on this, but MBSE is currently at a crossroads. It is the technology that is trying to be the one that influences the development of healthcare information systems. Healthcare is somewhat behind in adopting MBSE, model-based systems engineering, in developing new systems. And these are not small systems. We're talking about system of systems, complex systems. So I'm using the MBSE methodology, and if you stare at this long enough, you'll begin to see some logic here. But I'm moving on to the next slide. This is an example of application of MBSE to the hacking of sensors in hospitals. This was developed 3 years ago, and we presented this at the INCOSE International Workshop 2016 that was held on January 31st, 2016 in Torrance, California. And this is a description of what happens when a sensor, such as an infusion pump, breaks down in a hospital. Infusion pumps don't just get bought off the shelf and installed. They have to go through a hospital approval process. Once they're installed and they break down, then we go through all the ILAD checks. The middle of this diagram shows you the safety, availability, verification, validation, config management, integrity. You've got 2, 4, 6, 8, 10, 11 checks that the hospital has to do or get done somehow with the help of the manufacturer of the pump or with the help of their own IT shop. Typically, it's a combination of their own IT shop and the manufacturer of the pump to fix the pump. Make sure that that particular scenario doesn't happen again. Approve the device and put it back. So this was a simple application of MBSE to that scenario, that use case, where an infusion pump was hacked, broken down, and now what do you do to get it back working, operating? The pumps are all connected to the internet, by the way, because their software gets updated periodically through patches. And so if they're connected to the internet, they're vulnerable to hacking. So how do we plug the holes? And we presented a whole scenario here at this workshop almost 3 years ago, 2.5 years ago, plugging on how to plug the holes. I'm not going to dwell on that here. Next slide. This is just an application example of MBSE. Next slide shows you another example. Here we have various actors. We have requirements, the cost, the device. Let's say the device was hacked. The provider, the patient, provider, technician, all these actors are connected with specialization generalization symbols from SysML. They use various activities, these actors, to fix the problem of hacking and then store whatever data that the sensor provides in their local electronic health record, which you see here on the bottom right side of the diagram, through a cloud, the local cloud of the hospital. The question becomes, what happens when this sensory data has to go to some other doctor who's sitting in another cloud? And he wants to access this for remote diagnostic purposes or what have you, various scenarios come into play. And that is shown in the next diagram, where we see the cloud-to-cloud interaction happening in this diagram, which shows 4 swim lanes. And you see the Cloud A, where Bob may be sitting, Cloud B, where Alice is. And we have the Federation Manager that I pointed to in an earlier diagram. And each of these ovals, or rounded rectangles, represent activity. So the first thing that Bob has to do is get through his security and identity access management software. If that bounces Bob, he's not even going to go anywhere with getting into the cloud system. So after the identity access management software does its thing, he gets into the network, and basically he's going to approach that Federation Manager. And these are the types of services that the FM does. And the DLS is a distributed ledger system, the blockchain system. So you have a catalog of services that the other cloud has published. Bob would have to see what he wants by looking at the catalog. He needs access to the catalog. resource discovery. There's a smart contract. If Bob wants to pay a bill, there's policies, of course, that Bob has to be consistent with, his roles and the identity and so on and so forth, his membership. All that's validated by the FM. These are the services in this new standard that I was talking about. The standard is called P for Peter 2302. That's not yet published, but it's almost there. Cloud B, who's receiving some information from Bob, could be a health-related transaction, receives it provided everything over here is good in the Federation Manager and connects to Cloud B successfully and transmit that information using some standard, some known healthcare standard that gets back to the ontology. Typically, the internet-based transactions use something called Fast Health Internet Resource, FHIR, which is a subset of the Health Level 7 standard, which has been there for several decades now. So FHIR would be the encryption model used to transmit whatever information it's transferring. And then Alice sends back an acknowledgement saying, yes, I received the information, an ACK or a NAC or no acknowledgement. And of course, that gets stored in their local database. What gets stored is not the raw data, but the hash code. The raw data would go into some storage, like an EHR, electronic health record system. But the hash code would be stored in the local distributed ledger system. So you've implemented a federated management, cloud-to-cloud communication network with blockchain. So I'm approaching the end of my talk here. The next slide basically shows you the various activities that I showed on the previous diagram. I'll skip through this quickly. And then the goals of my exchange here is to be exchanging data in a readable, structured manner and in a secure manner. The next slide, please. You show the primary players here. Different domains would have different primary players. Healthcare has Food and Drug Administration as a primary player. You have to be consistent with their requirements. EHRs are not considered electronic devices, so they're exempt. But any sensory, like an infusion pump device, you'd have to be careful that you're not violating FDA requirements. If you're doing aviation, it's FAA. Of course, all the other guys would be involved in doing other things. The next slide, please. So the idea is to improve governance processes through doing model-based systems engineering, save dollars, reduce poor performance, and improve timeliness of delivery of historical data. That's basically those factors go into calculating the ROI. Confidentiality, availability, integrity are very important, as shown in the next slide. I'm going to just breeze through the rest of these to show you that the popular blockchain applications on the market today are Ethereum, Hyperledger, Fabric, for example. And these guys, Ethereum, for example, includes cloud computing in their layer 5 distributed applications. Adapt is a distributed application. So it's not like the blockchain folks are completely ignoring cloud computing. They're not. So the next slide shows you an application of bill payment in the healthcare system using Ethereum. Now, the important thing here is that the left side, whoever that is, requests $100, Dr. J does, and this could be me on the right. We're in two different clouds. Ethereum will bridge the clouds as well as implement the smart contract, which requires me to pay Dr. J $100 by keeping track of this payment automatically using the blockchain. Ethereum is a blockchain implementer. Next slide, please. This gives you the technical standards that would be needed to do this previous transaction. P2302 is in here, PKI for authentication, RSA keys, and various other standards. This was presented back in 2017, this slide. The next slide, please. And the next slide brings me on to the Interoperability Verification Initiative, and I'll let Ken Cureton handle that part of it.
Hey, Raj, voice check. Can you hear me okay?
Yes, I can.
Okay. All right. The goal of the interoperability verification effort is to most certainly recognize that you have to have government and industry standards for anything you're going to be doing in a federated cloud environment. It's absolutely necessary, but often it's not sufficient to guarantee interoperability across similar vendors, because almost all standards can be interpreted and implemented in slightly different ways. So consequently, you may have a vendor on one cloud that implements a standard and a vendor on another cloud that implements the same standard in a slightly different way, and you'll have interoperability problems. So we're suggesting that vendors need further guidance as to how to implement standards, especially in a cloud-to-cloud, a federated, or a coalition environment. And the idea is that we can assess interoperability across different vendor product lines within a vendor and across different vendors, in fact. And the idea is to provide some means of pre-integrating or understanding to how to integrate things. Otherwise, you wind up buying things, if you're a procuring agency, that are the lowest cost to procure, but often the most expensive to integrate in terms of the amount of time and testing required. So we've been working in the Network-Centric Operations Industry Consortium on patterns, frameworks, tools to measure, assess, and improve interoperability since 2004. And the idea was here on the IV framework, we'd have a process that would develop guidance for vendors. And then once the vendors follow the guidance, for us to assess their test results and to generate a interoperability risk assessment report, not pass-fail, but what is the risk of using this particular vendor's products and services in an integrated cloud-to-cloud environment. So we are striving to show the value of such things to vendors and the value to governments. And we're working on pilot programs to show proof of such value. The proof of concept programs that we're proposing are to identify an operational test scenario and some key interoperability attributes, in other words, barriers to interoperability that are consistent with the federated cloud philosophy and structure. Now, we mentioned healthcare because distributed healthcare ledger records in a disaster response or battlefield environment is a very critical need and an example of federated clouds where you have dissimilar products and services. For example, in a NATO environment, you have the federated mission networking folks plus some member nation equipment, not all of which will interoperate perfectly at first. So what we want to do is to make sure that the process we have will assess interoperability products and services and networks, preferably before you purchase them. So this guidance would go out to vendors. They would follow this guidance or at least recognize this guidance. Key value of that, by the way, is the value to the vendors is if they have assessed interoperability according to this guidance, that should improve their probability of global sales. In other words, people will recognize, much like you have something that's been certified by the Wi-Fi Alliance, you're likely to buy this Wi-Fi product and it will interoperate with others. Likely the vendor products will interoperate with others at least some level. And then the process for assessing and reporting how well they followed that guidance. Now we're going to then select a operational scenario, again, a healthcare scenario, using distributed ledgers, blockchain, etc., and to select actual items for integration using representative vendor products and services. run the test in the environment to bring things together, and then to apply all of the processes and document the results, especially did we speed up the integration process? If so, by how much? Did we improve interoperability? If so, in what aspects? Did we provide vendors and procuring agencies with enough information to help them develop the right products and services and to field the right products and services? So, again, the operational scenario, I'll go through these relatively quickly, is to look at something that is key in the federated cloud environment. We are going to characterize some interoperability barriers. We typically find, according to our scope model, that there are hundreds of interoperability characteristics, but typically only about 10 are dominant. In other words, they are consistent historical constraints or choke points for a particular scenario. The problem is that those 10 move around. Different domains have different choke points, but typically there's only a few, and you have to handle those first. Now, in the NCOIC, we've identified that the interoperability barriers could be technical, in governance, in culture, or in business issues, and altogether too often we focus on the technical issues and forget about the governance, cultural, or business aspects, which are often the key barriers, the barriers to interoperability. So the idea is that the measurement and control of these few interoperability characteristics will typically constrain the minimum level of interoperability, the threshold, and the objective or the goal levels of interoperability. And we've got to measure and control these barriers, these key interoperability attributes, before we go working on the other things. And again, stress, these barriers to interoperability are mission dependent. So on the second step, identify and characterize the process for guidance. And again, the goal is that vendors would want to follow this guidance, because if they are then assessed with the process for assessing vendor compliance, and that they can tout that as my interoperability is at this level, that should improve their chances for being selected by procuring agencies. It also should give them some guidance on how to replace legacy systems with their newer equipment. Third step, again, select a few representative vendor products and services. We'll do this with low-cost, widely available COT stuff, and we'll do things in an internet approach so that we can do a desktop environment, assess items relative to the guidance, generate interoperability risk assessments, as I described before, to show this is the expected risk of trying to integrate these products and services. So when we actually run the environment together, an integrate thing and exercise the operational test environment, again, heavily involved blockchain, electronic health records, and the like, and to visualize, we have tools for visualization and for assessing the interoperability functionality against the risk assessment, and then to compare that to see, did we provide enough insight to the folks doing the integration to improve speed, the time, because time is money, to speed up the amount of time it took to integrate that. So identify and document acceleration of the integration. We typically find, by the way, for a monolithic integrated environment, it takes a year or so to get the products and services to work together. In a cloud environment, of course, that's far faster. So we're trying to get this oriented towards something where in a networked, especially federated cloud environment, you'd far more rapidly, within hours or a couple of days, be able to assess what products will work, what will not, so that we then can generate a report that shows, for this particular scenario, evidence of the value of the approach and the recommended next steps for implementation. Again, the goal is to have procuring agencies eventually require such assessments as part of their procurement processes or their request for bid, and to at least, if you have two vendors with approximately the same procurement cost, you'd pick the vendor which has the lower interoperability risk assessment. That would be one of the reasons why vendors would want to participate in this. The other value would be that this would give vendors some guidance and feedback from governments as to what it is they're looking for in interoperability so that they could sell more products, more services in these environments. And Raj, that pretty much concludes my presentation. So why don't you do the conclusion slide?
Right. Please put up the conclusion slide 33. In conclusion, thank you, Ken. In conclusion, we find from a cultural perspective that implementing federated clouds and distributed ledger systems are disruptive technologies, meaning they make people uncomfortable. People with large databases out there, big data type bases, typically may not want to share data, may want to keep things to themselves, but they would like to get other people's data into their ambit. So these are disruptive technologies. It requires new ways of thinking, new ways of collaboration among data owners who in the past may have been reluctant to share. Business challenges their business models, operational models, even in the healthcare information systems arena. And so some of the other factors that we list here, you can read, but I want to say that standards such as P2302, FHIR, HL7, SNOMED, LOINC, for example, are very important, along with open source data where we can get that for implementing interoperability. So a standards-based approach goes a long way to help with interoperability, provided vendors agree on some minimum common level of implementation. These standards have many activities which are prioritized, but there's a core set of activities in all these standards that all vendors have to have in order to claim that they have implemented the standard. As long as they have that core set, you've got some level of interoperability that can be measured. And that's our message. So with that, I hand it back to Bob. Thank you very much, Bob.
Okay, thank you for spending the time and explaining the process to it. To those of you out there in webinar land, if you have questions, please type them into the chat box in the lower left, and we'll answer them. The couple of questions that came to me is Ken, during your discussion, you talked about using these standards and promulgating them with procuring agencies in hopes that would help create a driving function for providers to employ the standards. Does NCOIC have some kind of a plan for promulgating this concept and approach?
Yes, we are currently proposing with Allied Command Transformation, it's one of the three major branches of the NATO. This is the procuring agency for essentially the enterprise within the NATO, their enterprise core systems. Roughly, when NATO does a particular military or a medical disaster response or something like that, about 10% of the material is procured from common core practices. The others are contributed by the NATO member and affiliate nations. So we're doing a pilot program, hopefully later on this year, with the NATO core enterprise with the intent to show the NATO member nations, the U.S. and the European Union in particular, the value of following this process. Again, giving guidance to vendors, assessing vendors' compliance to the guidance, and having them include that in their national as well as their enterprise procurement activities. And again, I want to stress, for many vendors, having some sort of a stamp or a pre-indicator of how well we've implemented the standards for dissimilar practices would enhance interoperability. So that's what we're doing with the NATO, and hopefully the member nations see the value in this and implement that as well.
Okay, so the hope would be that the standards established for activities involving defense organizations would then be observed by the civilian organizations and then begin to percolate out into the larger healthcare community.
That's correct, especially since the government organizations that we're working with, it's not so much for military operations in Afghanistan and other places that we're interested in. There are issues in defense services and supporting such things. It's mostly disaster response and healthcare activities. If we were to look at the difficulties, the cultural and the governance difficulties in exchanging electronic health record information just between NATO member nations, interoperability aspects of that is enormously difficult. We're hoping to work with them to show how that can be done for disaster response in other scenarios.
Okay, so you're already working out into the civilian healthcare world in that disaster response scenario,
Exactly.
and hopefully that there are enough of the U.S. agencies involved that that will help transfer the information over from the European arena into the United States.
Yes.
Yes. Allied transformation is largely participation from many nations, but it's heavily in Department of Defense because it's in Norfolk, Virginia. We also have the National Institute of Standards and Technology and others. Raj had mentioned the P302, 2302 standard and others being developed. So we have government agencies in the U.S. That are actively involved in all of this as well.
Bob, there's a number of state governments that are interested in rapid response capability in the event of cyclone, tornadoes, other natural disasters also. And we are trying to expand through this workshop that we held last November, for example, the awareness of the technologies that are currently available.
Yes. Certainly there's a lot of application for this in the United States, and primarily civilian. But then again, at the state level, you pretty quickly involve National Guard, and that's one very clear conduit from things in the military world over into the civilian world, simply because of the working relationship there.
That's right. It's a first responder focus at the state level, not so much the military.
Okay. Well, we've reached the end of our period. I want to thank everybody who signed in, and my thanks again to you, Raj and Ken, for giving us a great briefing.
Thank you very much. Appreciate it.
Hold on just 1 second here. Let me stop the recording. Okay.
Bob.